patient in the ER a few months ago, and she was pregnant, and she was like a G26, P15. I think this is like a Schmitz bad prognostic sign when your number of G's equals your age. That's not a good thing. And she had come in with some vaginal spotting, and we did an ultrasound. Baby looked okay, labs looked good, but we were still waiting for that type and screen to come back. And at my hospital, it can take an hour, 2 hours for that to come back. So I go in the room and I'm like, ma'am, by any chance, do you know your blood type? And she goes, oh yeah, I know my blood type. I was like, great, are you A positive? Are you B negative? What are you? And she looks at me very quizzically and says, no, my blood type is red. I was like, well, that's good because we're fresh out of alien blue blood, so if you need a transfusion today, you're good. So it made me laugh when I saw this because I'm apparently not the only one who's had this experience before. This is a thing. So we're going to talk briefly today about blood types. What do you have to know about blood transfusions? What are the indications for blood transfusions? And let's go through some of those major transfusion reactions that are uncommon but can be deadly, and we need to know how to treat them. So where do blood products come from? When you go to the American Red Cross and you donate blood, they siphon off whole blood. And in the military, we transfuse people, and we transfuse actually whole blood. Because when patients are bleeding, they're losing more than just packed RBCs. They're losing platelets. They're losing coagulation factors. But in the United States, sort of by necessity, we have to fractionate blood into its components. And so when you give blood, we siphon it down, and we break it into red blood cells, which make up about half of your blood volume, plasma, and then your white blood cells and platelets, which make up the remaining about 1%. And then we store it. So with platelets, those are actually stored at room temperature. If you try to freeze those, they become inactive. And this is why, by necessity, we have blood products that are now component therapy. When I talk about blood products, we're going to talk about really three main things: packed RBCs, FFP, and platelets. I'm going to touch on cryo, but it's very rare that we use this in the emergency department, so I'll just go over briefly what that is. So here's in a nutshell, in about 15-20 minutes, what you have to know about blood products. Packed RBCs. 1 unit will increase your hemoglobin by about 1 gram per deciliter. It'll increase your hematocrit by about 3%. Why do we transfuse packed RBCs? Primarily, it's to increase our oxygen carrying capacity. So there's 2 real reasons we give packed RBCs. 1 is you're bleeding, or 2, you have very severe symptomatic anemia, and we're trying to increase that oxygen delivery. The guidelines will vary. Most of us will start transfusing when they get below 7 to 8, but if you're a cardiac patient or a vascular patient, they want you at about 10. And of course, it depends on your symptoms. If this is someone who lives at 6.8 and they're asymptomatic, I don't automatically transfuse them. But we're at the beginning of the academic year. At my facility, we have both a PA, emergency medicine residency, as well as a MD-DO medical residency. And this time of year, I always get that phone call from somebody upstairs that says, Dr. Schmitz, I know you called me about this patient, but I don't really think he needs a blood transfusion because his hemoglobin is 9. I mean, his numbers look pretty good. And I'm like, really? Because the bucket of blood in his room would say otherwise. So remember that in acute blood loss, the numbers take several hours to catch up with the actual patient. So we don't transfuse just by numbers. It has to fit with your clinical exam. Platelets. The easy way to remember this is that we transfuse platelets 6 at a time. It's what we call a 6-pack. And each 6-pack should increase your platelet count by about 60,000. Transformation guidelines are generally if they're asymptomatic, if their platelets fall below 10,000, and if they have a major bleed at about 20,000. FFP. So what is FFP? It contains a number of coagulation factors and fibrinogen. So we use FFP when we want to transfuse someone who has liver disease, who's on Coumadin, or as part of a massive transfusion protocol when we have to give back all of those coagulation factors. It's rapidly being replaced, though, now by PCC. And the problem with FFP is that it's a lot of volume. So each unit of FFP contains about 250 cc's. And so if you transfuse 4 of them, which we typically do together, that's a whole liter of fluid. And you think about the patients who have Coumadin overdose, they're on Coumadin because they have AFib, they have congestive heart failure, and now you're giving them a liter of fluid, and that can actually make them worse. So the benefits of PCC, how many people here are using PCC that have that at their facility? Not many, so a few major academic centers are using it. With PCC, it's fast. You don't have to thaw it, you don't have to type it. You can give it in within a matter of minutes, where FFP goes in over hours. You have a much lower rate of transfusion reactions, and it costs about the same. And so a lot of places are now replacing it, but if you don't have PCC, FFP is a good go-to to replace those coagulation factors. Again, I'm just going to touch on this because we really don't use cryo very much anymore. There is really no firm transfusion guidelines. It's useful for people who have DIC, sometimes massive bleeding and hemophilia. I think in 15 years I've used this once, and it was on a hemophilia patient. This is what I picture the mosquitoes in Las Vegas, what they do when they belly up to the bar. And on draft, they have type O, A, B, and AB. Right? These are your 4 major blood types. What you have to know from here is what is a universal donor. So when you want to give someone crash blood, you're giving them O negative because they don't have any blood antigens. The caveat here is that in a trauma patient, if it's a male, you can actually give them O positive because we're not worried about the Rh factor. And what about the risk of transmission? So back in the 70s and 80s, blood transfusions were kind of scary. We know a number of patients contracted Hep C, HIV, other diseases from that blood we transfused. And so you may get asked that. If you're doing the consent and the patient says, what is the risk to me? What do you have to tell them? Well, nowadays in 2018, the risk of getting hepatitis C or HIV is about 1 in 2 million. It's very, very low, so you can reassure patients that the blood bank checks our own blood multiple times. It's a very safe procedure, but there are still some risks associated with it. So to sum up the main points from the first part here is packed RBCs, 1 unit will increase your hemoglobin by 1% and your hematocrit by 3. Platelets, you're going to transfuse as a 6-pack, will increase your platelet numbers by about 60,000. FFP, each unit contains about 250 cc's, so it's a lot of volume. You have to be careful with patients with CHF, but it's used in patients who have major coagulation deficits, Coumadin overdose, or liver failure. O negative is your universal donor, and the risk of transfusion, mainly from hepatitis C and HIV, is about 1 in 2 million. So let's do some cases. So this guy comes in, he needs a blood transfusion. Let's say he's got symptomatic anemia. You give him some blood, and the nurse calls you and says, hey, this guy, he's got like a low-grade fever. It's kind of scary, right? What's going on? So you go back to reevaluate him, and he's kind of picking his nose, picking his mustache. He looks pretty chill, though. He doesn't look toxic. And so you stop the blood transfusion, you call the blood bank, you want to make sure nothing else is going on, and you watch him for 4 hours. And that's it, that all he has is a fever. This is a simple, febrile, non-hemolytic transfusion reaction. This can occur either during the transfusion or up to 4 hours afterwards. The mistake here would be to assume that this was a simple non-hemolytic transfusion reaction, because an actual ABO malalignment can occur and look the same way initially. And so the first thing you want to do when this happens is stop the blood transfusion. You want to get a sample from the patient and send the blood, and you notify your blood bank. But if all this patient has is a simple low-grade temperature, you've watched them, you've confirmed you gave them the right blood, the treatment is simple. It's just acetaminophen. If this is a patient who has a bone marrow transplant, who's coming in frequently for blood transfusions, you could actually offer them leukocyte-reduced blood, and these have a lower risk of infection and fevers. Case number 2, this guy comes in, needs a blood transfusion. He gets some blood, and the nurse calls you and says, he's getting kind of a rash. You're like, uh-oh, something's going on, let's go check on him. So you do, and he looks like this. He's pretty happy, he's non-toxic appearing, but he's now got this rash. What is this? This is a simple allergic urticarial reaction. Very common. This is the one type of reaction that you don't have to stop the blood transfusion. We can just stop it and give it Benadryl and ask if this has ever happened before, but it's fairly common. There's really nothing else you have to do for it aside from the diphenhydramine. This is opposed to this guy who comes in. He needs a blood transfusion. You get some blood, and the nurse calls and says he's got a fever. And you go in, and he looks shocky. He looks nothing the same as he did an hour ago. And he looks sick. This is one of two things. This is either an acute hemolytic transfusion reaction, or this is sepsis. So the acute hemolytic transfusion reaction can occur, again, during the transfusion or up to 4 hours afterwards. This is a true emergency. And this is why when we give blood transfusions, we start them very slow, because it's proportionate to how much blood they get. This is almost always a human error, right? Someone who had the same name or the wrong birth date or something happened with the blood bank, they sent up the wrong blood, someone didn't check. And this is why it's so vitally important that we do the double identifier checks. Because if someone gets the wrong blood, the recipient's antibodies just wreak havoc. They attack that blood that's being transfused, and they start causing cell hemolysis. Mortality is really high. It's 1 in 30, and it's almost always due to this ABO incompatibility, and it can lead to rapid DIC, renal failure, and shock. Well, what do they look like? They can have a fever. It's usually high, but sometimes just 1 or 2 degrees up above normal. But they usually look shocky. They're diaphoretic. They have a fever. They have flank pain. They may have hematuria, and they look shocky. The other way I've heard of this present is when they actually have pain at the infusion site. So any of those things should ring some alarm bells that you need to act fast. I won't go into the details of how this is done, but the first thing the blood bank is going to ask for is a Coombs test, and it's called a direct Coombs test. The simple way is when you draw the blood is put it in a test tube, you hold it up. If it looks pink and frothy, that's not good. That's not good. And what's happening there is you're getting that agglutination of the antibodies and the antigens, and it's causing that blood to sort of clot. So the first thing you want to do is stop the transfusion. Right? We don't want to give that patient any more blood that he's going to attack. You want to recheck the patient, you recheck the blood, and you send down samples of both to the blood bank. You notify your blood bank right away, and you're going to start drawing additional labs. You want that direct Coombs test, another type and cross, a chemistry panel because these patients can go into renal failure, and check your hemoglobin. Treatment is mainly going to be supportive. There's not a whole lot that we can do at this point to undo what's already been done. But you can try to minimize the damage by giving them fluids. We want their urine output at about 100 to 200 cc's an hour. Because you're having hemolysis and those cells are lysing, patients can have hyperkalemia. So you want to get an EKG and treat the hyperkalemia if it's present. Sepsis. So sepsis is pretty rare. We talked about with platelets, because they're stored at room temperature, they're at higher risk of getting infection, to be cohabitated by bacteria. Or perhaps a patient was sick when they donated blood but didn't really have symptoms yet, and that bacteria continues to grow in that sample. So if you transfuse someone and they get actually sepsis from that transfusion, it is very, very rare, but the same thing, you're going to stop the transfusion, you culture the patient, you cover them with broad-spectrum antibiotics. So case number 4, you have this very sweet-looking girl who comes in who needs a blood transfusion. She gets blood, the nurse calls you, she's looking like she's short of breath, looks very uncomfortable, and she looks like that. What do we do for her? So this could be one of a few different things. One of them is a severe allergic, almost like an anaphylactic reaction to the blood you just transfused. She could have TRALI, which is a transfusion-related acute lung injury, or my favorite from San Antonio, the TACO, the transfusion-associated circulatory overload. So what do we do for these? I've never seen one this bad, but this patient can present with anaphylaxis, and it literally is, within minutes, a reaction to the blood that was transfused where they can get angioedema, they get swelling of their airway. And you're going to treat this just like you would any other severe allergic reaction or anaphylaxis. Right? They get the full 9 yards. You want to worry about their airway. They're going to get epinephrine, sub-Q, IM, IV, and really maintaining their airway and getting your most experienced airway people at the bed. Trolley is something that we started to see more commonly in the last 10 years after we started doing massive transfusion protocols. And we noticed that a subset of patients who were getting these blood products would go from fine to really not fine and almost look like a pulmonary edema or pneumonia within minutes of getting a blood transfusion. And we're like, what is going on? The theory is that we are developing these HLA antibodies, and that it's not that they're fluid overloaded. These are healthy patients who have no history of CHF, and they get a blood transfusion, and they go downhill very quickly. So what's going on? We think it actually causes leakiness of the membranes, and so they're starting to put fluid where it shouldn't be. It's not that they're fluid overloaded, but they've got fluid going into their lungs and their third spacing. We don't know why, but it seems to be more common in female donors, and there's a reduced incidence in male donors now that we've screened for HLA antibodies. The diagnosis is made by looking like a non-cardiogenic pulmonary edema associated right after a blood transfusion. They're tachypnic, they're tachycardic, they're hypotensive, and they have a fever. And so their chest x-ray, this is before and after in a matter of hours. They're developing what looks like a really bad pneumonia, but it doesn't quite make sense. And it was associated with these blood transfusions. So how do you treat these? The treatment is largely supportive. You want to maintain their airway and their hemodynamics, but you don't want to give them Lasix, because again, for trolley, the problem is not that they're fluid overloaded, it's the fluid is in the wrong space. And actually giving them diuretics will put them into renal failure. And then there's TACO. So this is kind of similar, but this is in patients who already have a history of heart failure. And you give them a blood transfusion, and within hours, they look fluid overloaded, because they are. And you're going to see increased JVD, their blood pressures increase, their BNP may be elevated, and their chest x-ray looks like this. So this is similar in that within hours of a blood transfusion, they go into pulmonary edema. These folks actually are fluid overloaded, and so these guys, you do want to give them Lasix. You want to diurese them in addition to the supportive measures to maintain their airway. What about pre-medication? Nurse comes in and says, hey, I've got this guy who needs a blood transfusion. He tells me every time he comes in, he gets that low-grade fever. Can we just go ahead and preemptively treat him with Tylenol? Or maybe he always gets a rash. Can we just give him Benadryl? And we have a couple of patients who will ask for that when they come to the ED before we give them blood, because it happens so commonly, and they want to know if we can try to minimize that. So this was kind of an interesting study. It was a prospective randomized double-blind controlled trial, and they gave 315 hem-onc patients. Half of them got Tylenol and Benadryl, and half got placebo, and they followed them forward. And what they found was there was no difference between the two groups. Even in the subset of patients who said that they had had all these reactions in the past, it really didn't seem to make a difference. So the answer is it's probably okay either way. I think most people are comfortable pre-treating with Benadryl for the allergic sort of urticarial symptoms, because that's the one type of transfusion-related reaction where you wouldn't stop the transfusion anyway, and it's sort of a benign course. The concern or the risk with pre-treating with acetaminophen is that you're masking the effect of a possible transfusion reaction. And if they truly are having an ABO incompatibility, you want to know about that sooner rather than later. And so I don't routinely prophylax. So the key points here, if you suspect something's going on, you've given a transfusion and the nurse notifies you the patient is not doing well, the key actions you want to do are, number one, stop the blood transfusion, notify the blood bank, and start drawing some labs. And the things you want to send are the Coombs test, ideally a direct Coombs test, your type and cross, your chemistry, an LDH, because it gives you an idea of how much your cells are hemolyzing, and just look at the test tube, look at the blood. Does it look pink? Does it look frothy? That should scare you. You want to check their urine and maintain their urine output of 100 to 200 cc's an hour. And if you think they may have sepsis, you can draw some cultures. This is a guy who got into a bar fight, maybe in Vegas. He needed a blood transfusion, and some quick-thinking doctor took a line from the plasma TV to give him a transfusion. Unfortunately, it didn't help his case. All right, so real rapidly to sum up what we learned here. So patient comes in, he's got a low-grade fever. You watch him, this is the only thing. He has got a febrile non-hemolytic transfusion reaction. The treatment is acetaminophen. Any patient who comes in after a blood transfusion develops urticaria. That's it. They look well. They're non-toxic appearing. This is a simple allergic reaction. You're going to treat him with antihistamines or Benadryl. Patient comes in. They look sick. High fever, shock after a blood transfusion. This is bad. This is one of two things. It's either sepsis or an acute hemolytic transfusion reaction. You're going to treat these patients aggressively with antipyretics, vasopressors, fluids, and possibly antibiotics if we're not sure if this is sepsis or not. A patient who comes in respiratory distress. The first major branch point are they hypotensive or are they hypertensive? If they're hypotensive, I'm thinking about trolley, and I'm thinking about anaphylaxis. If they're trolley, they have a fever, they have what looks like pulmonary edema, but they're not fluid overloaded, they have no history of CHF, they just have this schmutz in their lungs afterwards. I'm treating them with supportive care, but not Lasix, because the problem is not fluid overload. If they have anaphylaxis, I'm treating them with epinephrine. And if they're hypertensive, I'm thinking about TACO. This is your transfusion-associated circulatory overload. And these patients are overloaded. They do need Lasix, and they should get better. And that's all I got for you, and hopefully we'll get you back on time. Thank you very much.